I changed the title a bit. I didn't like the discussion of tombs, so I said that this is optimized bleed prevention throughout the lifespan. These are my disclosures. I'm going to approach this through issues related to life stages of an individual, discussion of levels and how that impacts optimal bleed prevention, and also discuss a bit the products and trends in treatment and how that impacts our ability to deliver best care. We can look at this from a variety of ways, but what's important to recognize is that optimal bleed prevention is not just the individual or the male with hemophilia A and B, it affects females as well. And so we have to have considerations of gender, and we also have to have considerations that go across the lifespan. Our work can start with young girls, especially if we know they're a carrier. It progresses to when they may become pregnant and carry an infant who may be affected, but also issues related to their delivery and safe care. It affects male neonates and how we approach them in terms of delivery and neonatal care. Our care transitions into infant and toddler, and then progresses as children age to teenagers, become young adults, and then adults and as they age. And through all of these lifespans and genders, we apply and have different tools at our disposal, including the ability to diagnose individuals, provide tailored education, look at specific bleed management and prevention, and then also look a bit wider than our hematologic perspective to issues related to their general health and how hemophilia affects their general health and how their general health affects their hemophilia care. In the end, one size does not fit all, and we need to develop personalized care approaches for every individual. And all of these things include a variety of different perspectives of looking at how we deliver care. It is their level and their phenotype. It is their specific factor deficiency and their targeted trough, but it's much more than that. It's their individual pharmacokinetics, the product they utilize, what comorbidities they may have, including inhibitor development, their specific life stage, the level of activity the individual has, their gender, and their joint status. So looking at this continuum, you can start by looking at different things. I'm going to start with gender and life stage and then discuss deficiency and level. And it's a little bit different than how we usually approach it. We usually dive into a deficiency and level, but I think the issues related to gender and life stage are becoming more apparent and important. So starting with young girls, we can often have the ability to identify potential carriers, and that gives us important touch points for education and counseling and ongoing care. We have genetic testing now, which we didn't have 20 or 30 years ago, and that gives us very accurate measures for determination of carrier status. That also gives us the opportunity, once we know someone is a carrier, to establish their baseline level, and through that, the need for hemostatic therapy for that woman. Planning for interventions, including pregnancy and delivery, and preemptive understanding and counseling for development of heavy menstrual bleeding and its prevention. It allows us, once they become pregnant, to determine fetal gender, and then plan for a safe delivery and early diagnosis. We can follow the woman throughout her pregnancy, look at her levels, and provide a safe plan for her, not just for the baby, but for the woman, to deliver and to not have excessive bleeding. We can anticipate excessive postpartum bleeding and plan for that and prevent it. We know that levels less than 50% may necessitate treatment, especially for interventions that are invasive. And miscarriage is generally not increased, but postpartum hemorrhage is. What's important is many carriers are really unaware of their status during the first pregnancy, and this is unfortunate. In the United States, it's approximately 91% of carriers. So some of this is due to the fact that 30% of cases are sporadic, but this is not all due to sporadic cases. This may be due to lack of family transmitting education about the fact that there's hemophilia within the family, that individuals are at risk, but it also may be on the provider side from lack of testing and going through the family tree appropriately. We know females experience bleeding symptoms, and so we have to be more careful about identifying these individuals at risk. Delivery of an at-risk male is important considerations. We know the risk of intra and extracranial bleeding is higher in vaginal delivery, and it is very important to avoid instrumentation. It's important to discuss the potential provision of elective C-section, although that can have pluses and minuses for women, especially during their first pregnancy. We can perform cranial ultrasounds in patients with severe disease. It may not detect all bleeding episodes, but it is helpful, especially with traumatic deliveries. We know that prematurity can increase the rate of bleeding across all deficiencies and can complicate care. Of all affected patients, approximately 70% are diagnosed in the first month of life, and 1/3 is due to bleeding, and 2/3 is based in family history. So it would be better to move that needle more towards knowing that it's based on family history rather than the occurrence of a bleeding event. Neonatal bleeding is more common in severe deficiency, but it does occur in mild and moderate disease, and we need to remember that. And interventions can unmask undiagnosed patients. Very important is to educate families at birth, to alert them to the signs and symptoms of bleeding. So even though you have done presumptive education and care for the affected carrier throughout their perhaps life and pregnancy, again, a different kind of education is needed at that time to tell them when to alert the physician to potential bleeding episodes. We also talk about different things at that time with an affected infant. If you have a new family that has not been able to have all of those touch points with a known carrier, it's very important to go through the family history, identify other female carriers at risk, look at their level of deficiency, develop treatment plans. And for the infant, again, the affected infant, development of a treatment plan very early in life is important, making sure that they have access to product at home, that there are general safety measures available within the home, and to discuss the psychosocial impact of the diagnosis on the family. Again, important to reach out to the primary healthcare provider who provides pediatric care to the infant so that that care can be delivered safely. This is an algorithm that looks at when you have an individual with hemophilia, how to go through the family history and determine whether there are other potential individuals at risk and to find the individuals, the female individuals, for which care should be provided. As the infant becomes a bit older, it is very important to continue to reinforce education. Education is not a one-time event. You can never expect a family to hear a lot of information and to take that in and to really understand it and to apply it in life. They need to hear it repeatedly. And you need to provide presumptive counseling through all scheduled visits during the first 2 years of life. Data from the United States CDC Universal Data Collection System revealed that 81% of babies bled within the first 2 years of life. So counseling and knowledge of when that can occur is very important to families. And the first joint bleed, the median age for that is 1.8 years. So if you're going to institute prophylaxis, you need to know these timelines in order to know when to intervene. We know that overall joint health is best maintained with the start of primary prophylaxis very early. That's at least by 2 years of age. It can be earlier, with some advocating for as early as 10 months based upon family history or individual care. Interval visits can be extended over time based upon the individual family, their ability to get that information and to document their knowledge and adherence. Important to remember, again, initiate prophylaxis early and reinforce education and counseling at whatever time you see a family. We know that inhibitor development is still a very severe consequence of hemophilia. It's highest within the first 20 exposure days. That risk period is still within the first 50 exposure days, but even after that time period, ongoing surveillance is needed. Early identification is very critical for intervention and bleed suppression. Inhibitors that occur and come to attention late often have interval bleeding symptoms that can be very severe and alter a patient's ability to achieve optimal care. Other issues during this time period include the choice and administration of an infusion product, whether it's standard or extended half-life, whether you're doing this by peripheral venous access or a central catheter insertion, the need to monitor for any breakthrough bleeding event and to make sure the family is aware of it and notifies you. And how do we define the targeted trough that we want to utilize for a specific patient? And I'm going to get to that a little bit later when we talk about levels and pharmacokinetics. Another thing to be aware of is joint and bone health and the adherence of the family. So again, important to reinforce education and counseling and ongoing surveillance. As children age to young adults, the ongoing prophylaxis and adherence is very critical to preserve joint health. We think as little toddlers are very active, have accidents, have joint bleeds, but sports activity and other activity that young children and young adults have is also another period of time where the risk of bleeding is higher. In the US, we know that less than 50% of patients and families adhere to the prescribed regimen. And so this is important to recognize and to have ongoing interventions to try to determine how we can help them do better. Use of a scale that is validated, that's self-administered by the family, can help us identify the domains in which families are having difficulty with adherence and to have targeted interventions to improve adherence as much as possible. We also know that, or we tend to think of adolescence as the highest risk time for individuals to not adhere to bleeding treatment regimens, but we know that young adults are 6 times more likely actually to be non-adherent with prophylaxis compared to adolescents. And perhaps this is due to lack of good transition strategies, lack of the ability of the individual to take responsibility for their own care. So we can follow published transition guidelines to assure that their completeness and that the individual is actually competent to take over their care. As young adults become true adults and age to get older, we know that we should continue prophylaxis to limit their long-term joint damage, but the individual may view that from a different perspective. Also, adults who didn't benefit from prophylaxis early in age can benefit from tertiary prophylaxis. So offering that to them, getting them to change their perspective on how they deliver their care, that bleeding is not okay, is a good thing to continue to discuss with the family. Issues that affect the continuation of prophylaxis include the individual's activity. If they're very sedentary, they may not think that there is a need for continued prophylaxis. Their specific issues, their joint health, their venous access, and the ability to have some infusion assistance if it's required, if they have difficulty themselves. Bone mineral density is really emerging as a very important issue in the general population, but also specifically in hemophilia. And issues as people age, including visual impairment, poor bone mineral density, and muscle weakness, all lead to an increased risk of falls. And so looking at algorithms to determine fall risk for individuals is important to alert us to putting in some kind of program for individuals to help prevent these. Exercise is very important. Keeping active throughout your lifespan, it's important for all of us. It's important for patients with bleeding disorders. It promotes healthy joints, muscle tone, body weight, bone density, and quality of life. Different forms of exercise provide different effects or benefits to the individual, and people choose the level of activity that they feel is best for them. It's important to encourage this, and we also need to tailor therapy. What's the best targeted level for any particular exercise, and how long do you have to have a level within a certain range to protect that individual against bleeding? As I said before, vitamin D deficiency is really an emerging problem. We've really encouraged people to use sunscreen to prevent skin cancer, but there are other effects of avoiding sun, including vitamin D deficiency, and we have an increased rate of osteoporosis. Approximately 65% of hemophilia patients have been shown to be vitamin D deficient, so screening for this and treatment can be helpful in their care. Obesity is a growing concern throughout the developed world. It increases our cost of care due to increased weight, and it has a negative impact on joint health, joint range of motion, increased bleeding events, and a poor mobility. Many of our patients have suffered the consequences of viral transmissions, including HCV, HBV, and HIV. This has affected their morbidity that they have encountered in life, as well as impacted lifespan. Although HCV can be eradicated and HIV controlled, the hemophilia care can still be complicated. We need to coordinate their care through a variety of subspecialists to make sure that other subspecialists are not performing procedures that we are unaware of or prescribing medications that may impact the hemostatic system, and that we're not providing the protection for the patient to cover for the use of that medication. Some of our patients, even if these infections are controlled or eradicated, suffer end organ damage, and that can affect their outcome with either hemostatic or hematologic manifestations. And the normal diseases of aging affect our population, and this includes, just for examples, cardiovascular disease, renal disease. And one thing we have to do, again, is preventative care, control those risk factors that we have some control over, including weight, blood pressure management, and lipid profile, to make sure our patients don't experience these events. These are some of the comorbidities that impact the hemophilia care, and again, the drug therapy for these can impact the risk of bleeding. An important thing to realize is that as individuals age or as they grow, they may have specific developmental or psychological conditions that impact their compliance or ability to deliver their own care. They may have issues related to cognition as they age. They may take different medications, and this all complicates care and makes it a bit difficult to tailor to the individual. And again, issues related to cardiovascular disease, including hypertension, atrial fibrillation, atherosclerosis, are all important in our population, require different interventions that require different hemostatic control. So let's shift a bit to talk about what levels then do we need to achieve in our patients to actually get optimal bleed protection. Well, we know prophylaxis is the standard of care, and that, however, is based upon the local ability, the local resources that are able to sustain and deliver that. The targeted trough is based upon the observation that bleeding frequency and moderate deficiency is less, so that's what we originally targeted, and we also were limited in the beginning by what we were able to reasonably achieve based upon the half-life of the product. We know that aggressive prophylaxis substantially reduces bleeding events and the development of joint disease, But breakthrough bleeding, even with aggressive prophylaxis, can occur. And when that happens, we need to look at the individual. What is the time under the area of the curve that that individual experiences that puts them at risk for bleeding? What's their activity? What's their joint status that may contribute to this? And what's the half-life of the replacement product? When are they infusing? What are their individual pharmacokinetics? All of these play a part in determining why that individual has experienced those bleeding events. Current data challenges the need for a 1% trough as a level, and really a higher level is optimal for these patients. Looking at some data, a level of 15% or higher may be required to really prevent subclinical bleeding. And we know with each 1% increase in level, we get an 18% reduction in bleeding risk. And the time below that 1% factor VIII activity is associated with increased risk of bleeding. So if that's what we're targeting, when is that occurring for that individual patient? We also need to understand that level we get back from a laboratory. What does that mean? Bioengineered products may have different biodistribution and hence bioavailability. So that specific factor level that we get with that product may not mean the same thing as that level that we get with a different product. A level required to prevent bleeding is based upon, again, activity and pre-existing joint disease, the stressors that an individual experiences, and their gender. So for example, women have gynecologic issues, they have menstrual periods, and the bleeding that they experience is different. And again, the duration of time at the tail end helps us determine when a patient is at risk. And again, what can be reasonably achieved with infusion products and what is economically feasible. So the goals vary based upon local economies, the product utilized, and the frequency of infusion. Again, what is in a level? You have to understand the mechanics of obtaining a level, the pre-analytic factors that contribute to that, and the product that's utilized and the specific assays, the activators, and the form of the assay that you're using in order to interpret that level appropriately for that individual patient. So talking about bleeding risk and baseline levels, we know the bleeding risk here is highest for individuals with levels less than 5%. It significantly decreases with a level of 10%, and probably around 15%, the risk is far lower, decreasing the rate of bleeding to a very minimal or negligible level. So the relative risk decreases is about 0.82 for levels of about 15%. You also have to layer upon this the level of activity. So this data shows you the odds ratio for bleeds by clotting factor level activity and the type of activity. So a category 1 is basically an inactive person, and this line shows you the level of activity for a person with less than 1% who is inactive across all of the graphs. Category 2 is where you might have some collisions. That might include basketball. In my state, I'd consider basketball to be a significant contact sport. And category 3 is a definite risk of collision, for example, wrestling. And you can see that a level of about 50% is needed for individuals to prevent bleeding episodes across these activities, and we can achieve that with infusion therapy if given prior to the activity. We know that, for example, with factor VIII, where the half-life is shorter than factor IX, that level will stay above 50% if you target about 80 or 100% for about 12 hours, which is far less than the length of the activity that the individual is participating in. So actually, the odds ratio is not that significant for these different levels of activity, so that the risk of bleeding does increase with increased activity, but if you adequately prophylax the person, you can prevent or suppress bleeding episodes even with significant activity. Individual pharmacokinetics are important. Infants and children have increased volumes of distribution and clearance compared to adults, but we know there's intra-individual or inter-individual pharmacokinetic variation as well. We can measure PK with limited time points, for example, through the WAPS Hemosystem, which can be very helpful in helping to develop a treatment plan for an individual to protect them, and longer-lasting products can help us achieve a trough level or a coverage to help a patient suppress bleeding. This is a theoretic PK curve. You can see that there's a therapeutic window, a super therapeutic event, levels that can occur for individuals. There's a duration of action period at which time you can reach a subtherapeutic level. And for hemophilia, we generally define subtherapeutic as that time period where there's risk, a significant risk of bleeding. The normal range actually may be tighter than the actual therapeutic range for an individual. Super therapeutic levels is an interesting phenomenon. We know that untoward events can occur, specifically thrombosis, but we don't know over what time period we have sustained super therapeutic levels that are required to unmask those events, and individual patient characteristics, including prothrombotic factors, weight, immobility, interventions can contribute to that. So what about a peak level? What peak level do we want? Does having a peak level matter? Some of these newer agents, including gene therapy, use of longer-acting products, or use of novel agents can help us achieve some of these levels, but there's still some things we need to understand about what the optimal trough is to achieve, to prevent the majority of bleeds, how far within that therapeutic window we really need to target, and do we need to go into the normal range to achieve our goals. Now we have a plethora of products from which to choose. We have plasma-derived recombinant products, standard, extended half-life, and we now have emerging novel agents. Inhibitors, we can't forget, remain a significant issue. We have some novel agents that can treat inhibitor patients, not all inhibitor patients, because factor IX with inhibitors, we still don't have a licensed novel agent to treat those individuals. So ongoing surveillance is very important. Choosing the best product for an individual patient can now be a difficult issue. These are some of the technologies that have been employed to extend factor VIII and factor IX half-life. Again, inhibitors are very important. This occurs in 30% of severe VIIIs and about 5% of severe IXs. Ongoing surveillance is very important, even throughout the lifespan, especially in aging patients where the normal immune mechanisms may break down and inhibitors may emerge. Early ITI is important in inhibitor eradication, and it has remained our mainstay for treatment of these patients. An increased understanding of the immune response and emerging strategies can help us perhaps expand our therapeutic options and our ITI success. We now have transformative products that are either licensed or in clinical trials or earlier in development. One of these agents that's licensed is Heme Libra. It's a novel agent for factor VIII deficiency with inhibitors. It is a humanized monoclonal bispecific antibody that bridges factor IXA to 10, substituting for the scaffold effect of factor VIIIA and providing hemostasis even in the face of a factor VIII inhibitor, which does not recognize the monoclonal antibody. Now, this antibody is not factor VIII. It doesn't have an on and off mechanism, and it has different binding capacity to IXA and 10 than native factor VIII. This is the results from one of the early trials using EMAsysm AB, and it showed an 87% reduction in annualized bleeding rate with the use of this agent when modeled against individuals using bypassing therapy episodically for treatment of their bleeding events. Now, EMAsysm AB is indicated for prophylaxis in factor VIII deficiency with inhibitors. It doesn't treat bleeding events. So when a bleeding event occurs, you have to treat it. What's important is the recognition of thrombotic events and thrombotic microangiopathy that can occur with the use of this agent, especially in association with APCC when used at a dose of greater than 100 units per kilo per day for more than 1 day. An anti-drug antibody has developed in one individual that required discontinuation of the use of this agent, but that's one of approximately 600 individuals treated, so that's not unusual for what we would expect with a monoclonal antibody. And ongoing studies that we have heard here have shown the use of this agent in factor VIII deficiency without inhibitors, also with very good bleed control. Gene therapy has really reached a new era in hemophilia care. There are multiple clinical trials that are ongoing in both factor VIII and IX deficiency. Most utilize an AAV episomal vector, although one novel trial is utilizing a zinc finger nuclease mechanism to insert factor IX in a safe harbor of albumin locus. The levels that are achieved vary, and the different constructs, as Dr. Pipe discussed, vary. And as yet, not everyone is eligible for these protocols, but tremendous progress has been achieved. So what I've discussed is how to provide optimized bleed prevention throughout the lifespan, including women, young girls, and approaching senior age, and applying a variety of mechanisms, including considerations for education, counseling, diagnosis, bleed management, prevention, and general health considerations. We have many opportunities throughout the lifespan to impact care, and we should utilize every one of them to help deliver best care. Care right now is rapidly evolving. We have our patients an opportunity to really live a long and active life. Novel agents have advanced care for many inhibitor patients and transformed their lives. Gene therapy may offer a cure and may offer another mechanism to induce tolerance for inhibitor patients. How all of our patients achieve optimal outcomes really remains to unfold, and equalizing care throughout the world really does remain a challenge. So this lecture is dedicated to Ivar Arsenius, a Swedish painter and author, and where once the horizon looked fairly dark, the now future is bright. Thank you.